Okay, well, good afternoon, everyone. Carol Ann just letting everyone in from the waiting room. So we're collecting all our registrants. Welcome back to week 2. We'll just wait a couple minutes for everyone to come in. I'll introduce myself. I'm Doug Sinclair. I'm coming to you from Halifax and been involved with the leadership program for a few years. So we're delighted. This is our second virtual program. And thanks for everyone. We had quite a few of you send your feedback, and which is fantastic. So we've got that, and a couple of things you noted from your feedback, which was absolutely correct. You wanted it to be more interactive, and we're still learning our virtual world here. But absolutely, I think the first topic was, more of a traditional presentation. Our concept was to give 2 leaders from different experience to really inspire us about leadership. The next 3 sessions, especially the next 2, but this one as well, will be very interactive with lots of back and forth. Because I think when we started, we said really that we're really doing this together. Though this really is a community practice. We have such tremendous expertise with all the registrants, so that's really important that we all work together. So anyways, as I said, I'm coming from Halifax. So before we start, I'd like to acknowledge that we are located within Mi'kma'ki, the unceded and ancestral territory of the Mi'kmaq people here in Nova Scotia. That land there was a treaty of friendship that was signed in the 1700s, and the concept was to share the land, work together on the land to protect the land, which I think is very timely with the various conferences going on about the environment. Very timely and reminds us of our Indigenous people really had it right, didn't they, when they signed these treaties? And I think the other thing to note today on Remembrance Day, if you've noted, there's been a tremendous amount of recognition of I didn't really know myself the contributions of the Indigenous people, First Nations and Métis to many war efforts across Canada. Really quite remarkable stories that I hope people have had an opportunity to see. So with that little introduction, we're going to proceed into our session because time goes very quickly. So this session is a little bit different. This is also feedback from our previous virtual leadership session from last year, when we did get feedback that we had quite a bit of kind of foundational work in leadership, learning what it is to be a leader, learning about your own skills. But we did get some clear feedback that people wanted, being emergency physicians, you all wanted practical tips that, like next week when you go back to emergency, you can use them in leadership. So that's our focus for today. We're going to have 4 presentations that are fairly brief. I'll moderate and introduce the talks, and then at the end we'll have lots of time for question and answer and back and forth. And Eddie Lang, my colleague, is going to moderate that piece. So that's what we're going to do today. So we're going to, I have to share my slides here for the introduction. All right. Okay, so again, we're on our second, can everyone see those slides okay? Okay, we're on our second session. You can see here we had our first session to kind of set the table. Our second session is on practical strategies. You'll see backed by popular demand, our third session is on wellness and resilience. And our fourth session is on EDI leadership, follow-up from the CAPE program back in June. So lots of interaction to come. I would really highly ask people to use their chat. We'll be looking at the chat and interacting as we go along. So that's important because it really helps to facilitate as we go along. We have no disclosures except Dr. Eddie Lang does chair some educational programs which receive pharmaceutical sponsorship, but all those honorariums go into the research fund at University of Alberta. We haven't received any financial support, and no other conflicts of interest have been identified. You've seen our overall learning objectives, and as I said, for this session, we're really focused on a number of practical leadership strategy things that you'll see. All right, so our first speaker is going to be Dr. Eric Clark. And Eric is the Deputy Chief of Emergency Medicine at the University of Ottawa, so big hospital academic system, and he's the Deputy Chief. And usually what that means, I don't know what Eric's job is, but usually the Deputy Chief gets to do all the jobs that the Chief doesn't want to do, that usually include managing patient complaints and professionalism issues. And it sounds like scheduling is another one of those hateful jobs that a deputy chief does. So Eric is also the head of our CPD committee for CAPE. So over to you, Eric.
Thanks for that, Doug. I don't have to deal with complaints. There's another doc that takes care of that, which is great. But I am, scheduling and sort of operations is kind of under my umbrella, and I hope everyone can see my screen. And so, I'm from the Ottawa Hospital. I don't have any financial disclosures or conflicts to declare. I will be mentioning our scheduling system, but I certainly don't get paid by them. We pay them a fair chunk of change to help manage our schedule. And I'm not giving it a recommendation of any way. I'm just telling you how we use it. I work at TOH, the Ottawa Hospital. So we're 2 tertiary care hospitals, big and unwieldy, about 180,000 visits per year with learners from all levels. Okay. Our group is about 95 docs now. We're almost 100 docs now that we're scheduling. We have our clinical duties, our academic and administrative duties that are all put onto this schedule. Okay. And we are paid through an AFP. So if you work an hour, you get paid for an hour. And so that, of course, gets into how we schedule and distribute shifts and things. There are only 2 things that really get Emerge Docs excited about at a meeting or on a survey. One of them is your pay, and then second is your schedule. And so you start talking about scheduling and everyone gets very interested again. So this is where we started, and I've been doing this job for 6 years now, and we weren't quite on papyrus sent to us with a carrier pigeon, but it was manually scheduled by one doc who would write it all out and then send you your shifts. And clearly that needed to be upgraded as we got bigger and bigger group and a much more complicated schedule to manage. And this is where we're at now, and this is like 1/3 of what we get. We use Qgenda. It's one of the scheduling software systems. There's a bunch of them out there. So we have on-call for sickness. We have the civic site. We have the general site. We have teaching stuff. We have departmental meetings that are all on Qgenda that we help schedule and manage our lives. And this is where we've gotten to, and it's much more manageable. And I think we've helped create a schedule that the group understands and is happy with, which is incredibly important. We work a ton of off hour and bad hour and crappy shifts, and making sure we manage that as best as possible is super important. So what have I learned along the way? This is what I'm going to focus on. I'm going to go pretty quick, and hopefully, as Doug mentioned, leave some time to ask some questions or talk about some specific problems from other sites. And I'm sure people on the chat or within the group will have things that they've been through and maybe able to teach us as well. So the first thing I'll say is that patient care always comes first. And every time we're making decisions about the schedule, if I can show to the group that this is really about taking good care of patients and making sure patients are safe, my group comes along for that. Okay. They're okay doing more night shift hours when they see how unsafe it is on night shifts. If you're going to be working on, say, a P4R metric that necessarily the group doesn't necessarily see the benefit of, and if you're not from Ontario, P4R is the pay for performance metrics that we all have to sort of work under and get funded through. The group can have a tougher time saying, yeah, I want to do some more off-hour shifts to try and improve in a metric here or there, just to sort of be in competition with the hospitals from Toronto. Why, we're not in a race here with the Toronto hospitals. We're trying to take care of patients. So when you come from it from a patient care perspective, generally speaking, people can get behind that and see the benefit of even doing shifts that they feel, that they know that they don't want to do. The second thing is give individuals as much control as possible. So as many ways to control when and how they work as humanly possible, until it bumps into the point where the scheduler cannot actually physically make the schedule, okay? So we have every block of 3 months when we have to put in our request, we have a certain amount of vacation days, a certain amount of professional time off days, a certain number of weekends that you can ask for off. And we have pushed that to the point where the scheduler says, okay, I can't make the schedule anymore. We need to push it back just a little bit, because we all want individual control over our schedules as much as possible. One of my colleagues always has this, your wellness shouldn't negatively impact my wellness, which I think is the challenge of finding that sweet spot of accommodating the group as much as possible and the individuals, but also providing the service to the patients and covering the shifts that need to be covered. But if you can push this as much as possible, I think that's really important. We've developed a committee, so it's not just me. I don't actually even make the schedule. We have a physician scheduler who helps oversee and work with our scheduling software to actually create the schedule. We have a committee. You want that group to reflect everyone within your group. So you want some people who are fresh out of graduating. You want some people with young kids. You want some people with teenagers. You want some people in their 60s who are looking at a few more years and want to wind down, all helping to create a schedule and guidelines and rules for the group in terms of how they make the schedule and what you're allowed to ask for off. Because you want to know what's out there. You want to have a thought about what your group's culture is. And what I mean by that, so our group, we were kind of set up by Ian Steele, who everyone knows from his research accomplishments. But Ian was always about, we're in this together. So I don't care how long you've been here, you still work long weekends and we divvy them up. Your year 1 of practice and your year 25 of practice, we divvy them up even. And that's kind of been our culture throughout. That's our group culture. And that's how we kind of create the rules, and we modify and adjust as we adapt and evolve. Other groups have more of a seniority-based schedule, whereas the more years you put in, the better your schedule can get, the more time you can have off, that kind of thing. But that's not how we do our schedule. But really important to have a group there that's creating the rules for everyone to see that it's not just one person. There's no favoritism, and it's not with just one lens to how the schedule is made. This is one I learned early on, is separate the schedule maker from the tough decisions. And so my job is to present to the group the tough decisions, to say no to people. If you don't get your request in on time, you're not going to get any requests for that block. The whole group is not waiting for you to get your request in. No, you can only have a certain number of weekends requested off in a block, because we need to be able to create the schedule. Creating the schedule is a super hard job. It's a no-win job. You're the poor person as the scheduler who has to tell someone they're working Christmas and New Year's Eve and that Saturday. And so you want to try and show that it's a group creating the rules. I get to be the bad guy, sort of presenting the rules and telling people why they can't have that. The scheduler gets to work hard on making a schedule that's fair for everyone. And we found this really works quite well. You want as much transparency as possible. So first off, what are the rules? Everyone can see how many vacation days and professional time off days and yada, it goes on and on. Everyone gets the same set of rules. Everyone knows what the rules are, and they're embedded in QGenda, our scheduling software. So you can't actually break the rules. What are the accommodations? Now, some accommodations we love, like we have a couple night hawks who love doing nights. We don't mind letting them do tons of nights. Other people need certain accommodations to do their administrative work. Those are easy and everyone's behind that. And others are more personal in nature, family oriented. Of course, we're not getting into why so-and-so needs time off to be with their family. We don't want that. But we do want a sense of, to make sure that no one is getting preferential or preferred treatment or special treatment for another reason. Who is contributing? And what by that I mean is who's stepping up to help when a colleague gets sick or has a family issue. or has a work thing that pops up and we want to help them meet this academic or administrative goal? Is it always the same people picking up that extra shift, or is it equally distributed amongst the group? We want everyone to be able to see that. And lastly, explain to people and show people why and how decisions were made. So we have a group, we vote on it, but we also then show what the consequences of certain proposals or things might be. And this is where what I call the voice of reason, my scheduler comes in, because he can tell you, okay, if you want to do this and have this request, this is what happens to the schedule, this is how it's impacted, and this is exactly how many more night shifts you're going to have to work if we do proposal A or B. So everyone can see why and how we're doing things, and the hard realities of what happens when we make changes or adapt the rules. This is one I learned very early on as we started developing a group working on the schedule and setting the rules. I would get every other shift someone coming up and saying, we really got to do this. Okay, I really want that with the schedule. It was happening all the time, and I was seeing as many people saying A as B. And so I did a survey to the group involving all kinds of questions around the schedule itself. And I know everyone has survey fatigue, but when you title the survey is it's going to be about your specific work schedule, you will get 100% compliance on this survey. Okay. And we asked all kinds of things, from how early do you want the survey to how do you like casino shifts or not, and everything in between. Now, it did two things. One is it told us as the group, what does the group want and how can we help create that or get there? But two, it also allowed me to go back to the group and say, look, 5 people wanted the schedule a year in advance and 5 people want it 3 weeks in advance, because just that's how their life works. So it allowed people to sort of get out of their own worlds and say, oh, I'm in a group, we have to work together. And maybe what I want isn't necessarily what everybody wants. It was a great learning thing. And for me on shift, it actually helped. I got far fewer of those helpful suggestions or ideas from people, because they saw that while they might like this idea, there's a whole bunch of other people who didn't like that idea. And we've done this once. My plan is to repeat it. It'll be 4 years since that one, in about another 6 months or so, just to sort of update the group. We've got a whole bunch of newer, younger folk in our group, and we've gotten bigger. So again, just to get a sense of what the group wants and how are we meeting their needs. Part of my job is not just to make a schedule that works, but make a schedule that works well to get patients through, see them quickly, disposition them safely, and try and meet some P4R metrics, okay? And so you have to go to your hospital and get some data to sort of drive change. Physicians, nurses, we're a scarce resource, right? We have to use them as efficiently as possible. So you need to look at patient arrivals. When are they coming in, and how do we schedule for that? If you have something like P4R, who are the patients that we're losing out on P4R on? When do they come in? What problems do they have? And how do we schedule and create a system that directly deals with those tough patients to get at? If you can, and we're working on this right now, develop predictive modeling. So we have a young guy who went through engineering, is now on staff with us, and he's working on a predictive modeling where we'll be able to sort of toggle in different suggested changes to the schedule. Nursing, clerks, physicians, everything. How is that going to impact our flow through the department? If we have someone come in an hour earlier or an hour later, how do we best manage and use our resources? Make sure you're using your resources when the patients are actually there. And this is a slide from my place where the blue is patient arrivals, green is nursing hours and coverage, and the orange is the physician hours and coverage. And you can see that we're getting the physicians and nurses there 1 to 2 to 3 hours after the peak patient arrivals, and that's no good, right? We have physicians and nurses staying really late in the evening because we've got this massive backlog. So you want to take this, use this to shift everything earlier to see the patients as they arrive and get them out of your department. And this is, again, back to where numbers and looking at data becomes super helpful. I also love this because no one wants to be working later. And in this case, it actually showed we'll be better off having physicians in there earlier and home earlier, which I think we all want. use your entire ED team. And what I mean by that, so you can have your schedule, but you have to have matched resources. You have to talk to the nurses and see what's working, what isn't. Think about how your clerks and your ECG techs and everyone else is being scheduled. Again, to have them there when the patients are there at the maximum times of need, okay? Back to that efficiency piece of all of this. Delegate projects, the ones you think are good. So if someone comes to you and says, we really want to have a sabbatical policy, I think that's fantastic. Okay, let's get a few people together. Let's start working on that. Bring that back to the scheduling committee. Let's hammer that out and get a scheduling policy made. If it's something you don't think is going to be, or something you're not as interested in or don't think is going to fly with the group, well, then of course you need to step in and say, well, that's not really on our agenda right now. But if it's something you support, get those people working on it. They're your champion to help shepherd that through. Again, certainly in my position, I get into the weeds a little bit, but I try not to get too much into the weeds. Otherwise, I can't keep tabs on everything that's happening under my watch. And lastly, I'll point this out if you're interested in this stuff. These are some very good review articles in emergency medicine clinics. You can get through this if you're a CMA member, okay, from 2020. 3 nice, real good articles about queuing, modeling, and resource utilization and staffing. If you want to go and have 3 nice up-to-date review articles with great resources and references there, talking about some of the different ideas and how to use some of these ideas in smaller places with, say, higher numbers of low acuity patients, or bigger places like mine with higher numbers of complicated, elderly, complex patients, and what works in those 2 different kinds of areas. These 3 articles are really useful. And have a look and read through those. The references are all there with the articles as well. And you can go and see how some other hospitals tried things that worked and what they showed and what they improved or didn't improve. And then the last thing as I end, I'll say, don't be afraid to try stuff. Okay, we've done a number of little projects where we say, okay, for 3 weeks, we're going to try implementing this to see what happens, see what impact it has. Does it help? Does it not? Is it silly? We heard someone in Calgary had tried this and it worked or it didn't. Let's try it for a few weeks and see what we get out of it. If you get into the habit of doing these little trials, your group will be amenable to that and see that, A, we're trying stuff. We're trying to get better, okay, and be more efficient and faster. But that it's okay to try stuff that then doesn't work and fails. Maybe what worked in Calgary isn't going to work where we are for a whole bunch of reasons. Or maybe we just need to learn from Calgary and do something different. So I'll leave it with that don't be afraid to try things. So that's the end. And I don't know, Doug, do you want to take questions now or save all the questions till the end?
What we thought we'd do is just thanks. That was excellent, very practical. Like we said, Eric, we'll take a couple of questions now. There's a bit of conversation in the chat, and then we'll take a couple, and then we'll have lots more discussion when we get through all 4 talks. But one question that did come up, Eric, was when you have a real divisive issue, say casino, yes or no. I agree it's good to test these things, but how do you make, you make an executive decision by the executive of the department? Do you have a vote, or how do you make some of those tough decisions around scheduling?
Yeah, so at some point, yeah, the department head, myself, the other deputy head, we have to say, okay, listen, it's unsafe on nights. We need to address the patient needs there. No one wants to work more nights, but yeah, we're implementing more night coverage. And I had to do that. And that was one of those where showing people why we were doing it, showing people the need for doing it was really important. No one wanted to do more night shifts, but once they saw the need for it, they actually got behind it, okay? Having a good fulsome discussion about it and why we're doing it and explaining the rationale. And as I said at the start, invariably, if it's coming from a patient care and safety point of view, I haven't seen people really say no to that. It's, when I say, I'd like to be better at a P4R metric, some in the group are like, why are we worrying about that nonsense? I have a harder time selling that to my group.
Great point. Carolyn, you had a question. We'll take that question,
Actually,
then
not
we'll
a
move on.
question, if that's okay. It was more the issue
Sure.
for us with nights when we decided we needed more nights, and it was quite clear. What we also were hearing were about the late evenings. And so many people find the evenings that finish after midnight and even after 11 o'clock become very difficult early in the morning. They've got little kids. Most of us don't get out at 11 o'clock. So actually we switched to an additional night shift and shifted all evenings to finish by 11 or 12. And the difference, people said, within weeks of doing those shifts differently was huge, because everybody has their night shift system, but nobody thinks about the evening system. You got young kids, they don't care that you got home at 1 in the morning, right? But if you are on nights, everybody make sure you get some sleep and don't wake up mommy in the morning. Like it's sort of a different thing. It has made a big difference for people. So that's just a little hint that worked for our team, at least. And it came from within, just as Eric said, we got to do it. That come from within.
Yeah, and that's a great example of if you need to have a group of people working on this. It's so important, their scheduling, for our longevity as physicians. You need to have a group of people, and you need to have the breadth of your group. We have a half dozen docs who are 65 in our group. So we need to have some folks from that who are talking about what it's like to be 65 and what they need to keep working. And then we need some people with the toddlers, okay? I have late teenagers now. I kind of forget what it's like. But yeah, you need the whole group contributing to try and make it as worthwhile as possible.
Excellent. I can tell you what it's like when you're 65. Everything hurts for a while. Okay, that's fantastic. So we'll have lots more discussion ongoing with the chat and then at the end. So anyways, one of the things we also heard in our last session was that the leadership issues in rural medicine are really challenging. So we're delighted. Our next two speakers have a lot of experience in smaller centers and rural emergency medicine. So we're all really looking forward to what they have to say. So our next talk is Dr. Kernick, Amy Kernick. She's coming from Vancouver Island, and she works a number of rural locums, and also is chair of the small Rural Committee of CAPE. So we're delighted that Amy can join us. So, and her topic is on difficult conversations. I guess that feeds in from scheduling, doesn't it? Over to you, Amy.
Great, thank you for the introduction. Let me just get my screen shared for you all. Okay. Can everyone see that okay? Great. All right, so I am presenting today from the traditional territory of the WSÁNEĆ peoples of the Coast Salish Nation. And we're going to focus on some tips for difficult conversations. As mentioned, I have no conflicts of interest to declare. So we're going to start by looking at different areas of difficult conversations, and then I'll focus in on a few tools that I find especially helpful for leadership positions. So why bother learning this at all? Studying these soft skills might be hard to prioritize in your busy schedules, but the benefits are real. Your relationships, both at work and in your personal lives, will be stronger. Patient safety and health outcomes will improve, and your own job satisfaction and team morale will increase. At a time in the pandemic where burnout and staff shortages are at an all-time high, why not prioritize a skill that will lessen that? Finally, you'll be much more effective as a leader. You'll be more productive, and you'll have a team that actually listens because you're willing to talk about the hard stuff in a way that leaves everyone feeling safe and heard. So hopefully after this talk, you'll have a few more tools for that. This is an incomplete list of some of the difficult conversations that I find myself having in my day-to-day work. Many of these are taught in medical school, and we all develop approaches to the others early on in practice. I'm not going to focus on these today, but the other skills that I'm teaching, you can carry back to these issues as well. So beyond our care of individual patients, just by being emergency medicine physicians, we're required to be leaders. We lead department flow and resources, we lead resuscitations, we teach learners, we oversee allied health professionals. So even if you don't consider yourself in an official leadership role currently, you're still a leader and you're required to take on conversations such as these. A US study showed that issues like incompetence, poor teamwork, and disrespect are highly prevalent in hospitals. They often go on for years without anyone speaking up or holding their colleagues accountable. These sorts of issues can and do lead to patient harm, and they lead to staff attrition due to poor work environments. Only 1 in 10 interviewed staff actually spoke up when they observed issues about incompetence or unsafe environments. And they didn't say anything because they said these conversations are too difficult. So as leaders, these are the conversations we need to be skilled at and be able to model and encourage in others. These are some of the tools often mentioned in medical literature for difficult conversations, more specific to patient care scenarios. So I'm not going to delve into these today, but if you aren't familiar with any of them, I recommend that you take a look at them. Today, I'm going to focus on these 3 tools, starting with SPIKES. The SPIKES protocol, it was initially developed by oncologists for breaking bad news to cancer patients. Many of you have likely seen it and might even use it in your patient care. I bring it up as a reminder that many of these tools are equally applicable to non-clinical conversations. So especially the setup and starting. When you know that a crucial conversation is going to happen, it's helpful to plan ahead on what you want to say and cover. The way you introduce a topic can set the tone for the rest of the discussion. You want to find an appropriate setting, ideally somewhere that's private and comfortable, where everyone's sitting and doesn't feel rushed. While the conversation might have to happen, whether the other party wants it to or not, try to have some flexibility on timing. So ask if now is a good time. If the person needs space to settle their emotions, then take another time when they're ready to engage. Describe the problem from your own perspective, support any emotions that arise in the other person, and then summarize and determine the next steps. So the new strategies I'm going to talk about next, they fall under these categories as well. So if you need a memory aid, SPIKES is a great one. The next tools were developed by Patterson's group after decades of observational research, and it's going to cover crucial conversations and accountability discussions. A crucial conversation is one where opinions differ, there's strong emotions, and the outcome of the conversation has high stakes. Often at the center of chronic problems in our organizations, our teams, and our relationships are crucial conversations that we're either not having or not having well. These conversations are hard and we often try to avoid them. I'm sure many of you, and me especially, I'm definitely guilty of sending a text or an email instead of engaging in those face-to-face dialogues that are tricky. When conversations matter the most, our emotions run high and we're often our worst selves. Our sympathetic systems are in overdrive. We're wanting to fight, to push our views on the other, or flee and revert to silence. Sometimes we anticipate these difficult conversations, and other times they sneak up on us. For example, last week I was providing inpatient care. I thought that our liaison had communicated to an elderly patient's child that she was ready for discharge and that she had home supports in place. But when I called the daughter, she burst into tears. She was worried we were sending her loved one home to an unsafe environment. I couldn't get a word in to explain because she was on a spiral of emotion. So what was meant to be a casual phone call that your daughter's ready for pickup quickly turned crucial. Another category of conversation as a leader are those of accountability. Think about outcomes that you expect at work. For example, having orders carried out in a timely manner, nurses to notify you when there's a vital sign change or critical lab results. If you're in research, maybe you're a research partner or assistant finishing their grant proposal on time, your fellow committee or board members attending all meetings. A gap between what you expect and what you observe leads to an accountability issue, and one that often requires addressing. These areas of accountability are important as leaders, but for our teams to be effective, we also want a culture of universal accountability, where all team members take ownership and upward descent is also sought out and encouraged. For example, when the issue is the competence of a physician, less than 1% of coworkers, both nurses and other physicians, will actually speak up. And silence in these issues can actually be deadly. Some of you might know about the video, Just a Routine Operation, where a man talks about losing his wife during a sinus surgery, and that was from a lack of team communication. So before starting these difficult conversations, you want to think about what you really want for yourself, for the other person, for the relationship, and the organization. Sometimes we want something from the helpful column of motives, but once our emotions take over, our behavior can start to look like the unhelpful motives. When things get really heated, it's helpful to pause, do a pulse check, see if your words and your behaviors actually reflect what your motives really are. Often in a heated and high stakes conversation, we take what we see or hear and recreate stories. We guess at the motives of others, and we add a judgment of good or bad. These stories can be inflammatory and fuel strong emotions in us. And from this emotionally charged space, we respond. The other person does the same, and the conversation spirals out of control. Anyone with a spouse or a sibling has likely experienced this. By the end of this spiral, the only way to stop it is by having one person step out, reflect on their story, and stop the emotions at the source. So to be skilled in dialogue, you need to be able to separate what you observe, the facts, from the judgment and conclusions that you're making from the facts. A lesson from Dr. Rosenberg's nonviolent communication is that we need to take responsibility for our feelings. What others do might be the stimulus for our feelings, but it's not the cause. So we need to establish a separation between the feelings and the stimulus. There are three common stories that we tell ourselves: victim, villain, and helpless stories. All three of these stories are incomplete, and to improve them, we have to tell the other half. With victim stories, we minimize our own mistakes. We exaggerate our own innocence. So to fix that, you need to think about what your role is in the problem. With villain stories, we emphasize the bad qualities and the guilt of others. We assume bad motives. And the way to fix this is humanize the other person. Ask yourself, why would a reasonable person do this? And it doesn't mean that we ignore bad behavior, but we start with a positive assumption, because that helps balance the picture and helps keep our emotions in check. And the last is the helpless story. We're left thinking there's nothing we can do. We can either speak up and give the hurtful news, or we might lose our job and lose our relationship. So those are the only two options. But the solution is actually learning some dialogue skills, realizing that you can do both, maintain the relationship and have these conversations, and make some small steps towards what you want. The next step is adding to the pool of shared meaning. So thinking of conversations in this way reminds us that we need all perspectives out in the open. We don't want one person forcing their view and the other person clamming shut. With more opinions, you can make better decisions, which leads to more committed and unified action later. So looking back at Eric's examples, the best way to make the scheduling decisions is not one forced opinion, but everyone's opinions out into the pool. And then you can arrive at a consensus that everyone agrees with the same motives of patient care. So when it's your turn to speak, stick with the facts. In an accountability discussion, you want to describe the gap between what you expected and what you actually observed happen. It might be helpful to share your story, which is your interpretation. And the goal there is just to show why it's so important or impactful that you have the conversation in the first place. If you do that though, make sure to make it clear that it's your interpretation. Say things like, this leads me to believe, or in my opinion. And then encourage that opinion to be challenged. Encourage others to share their views and find out what their perspectives are. This helps to soften difficult messages and helps to reduce defensiveness and make it safe for others to speak. If you start to see the other person get defensive, either moving to violence or to silence, then it means they're not feeling safe. This can happen from a misunderstanding of motive, and it's helpful to share your intentions explicitly using a contrasting statement. So for example, that patient I mentioned trying to discharge home when the daughter became upset, I used a contrasting statement to make my motives and our mutual purpose clear. I said something like, it sounds like you're worried about your mom's safety. We're worried about that too. We're not trying to rush her out of the hospital, but instead we're working on home support so she'll be well cared for. We won't discharge her until that's in place. And then the daughter immediately relaxed because she was able to hear that we were on the same page. After the other party adds to the pool, don't just be ready for your next rebuttal. Find common ground by being explicit about what you do agree on. If you agree with parts but feel it's incomplete, build on it further. And if you actually have really differing opinions, then try to compare. Rather than saying they're wrong, you're right, which is an evaluation of their view, try to stick to the facts and look at how they differ and seek to find a compromise. Some words are true conversation killers. Just like with prescriptions, there's a do not use list. So for example, exaggerations like always and never often provoke defensiveness rather than compassion. So try to avoid these. For accountability issues, the reason people fail to live up to expectations is usually multifactorial. We often focus on a lack of motivation, but there's usually many other reasons at play, and motivation and ability are often linked. So using this list in the table can be helpful to brainstorm to find solutions and remove barriers. Involve the other person by asking questions like, can you help me understand why this happened, or what's keeping you from doing this? Start on the right side under ability and assume that that's the main issue, but eventually look at both sides. So once you clarify the issues, move on to solutions. Involve the other party early in problem solving, and it makes them more likely to feel part of the solution and more likely to implement the ideas. Just like with smoking and alcohol cessation, the motivation needs to be internal for it to be effective. Allow them to find self-motivation for change and discover their own reasons. It will be more successful than trying to implement rewards or punishments. If you use consequences as a motivator, start with natural rather than imposed ones. Try to encourage how it will affect them, an understanding of how it will affect them personally, how it's affecting you as a team, or your outcomes, or in our case, patient safety, and connect it to existing incentives like promotions. And then make sure you have a follow-up plan. So just like in resuscitations, we don't want to just bark out orders into the room and then hope that someone will do it sometime. Decide on who will do what and by when, and set a follow-up date. So in summary, as leaders in emergency medicine, we face difficult conversations in our clinical practice, teaching, team management, organizational roles, and we need to be experts in these conversations to help change organizational culture and to be effective as leaders. The first step is to create a safe space. Start with conversations, start with the objective facts rather than emotions. Try to recognize if you're telling a victim, villain, or helpless story, and neutralize it by telling the other side. Remember that the other person's behavior might be the stimulus, but we're responsible for our own emotions. Ensure that the other person feels safe and knows your positive motives and that there's a mutual respect and purpose. And then for conversations that deal with accountability issues, work together on the solutions, look at both motivation and ability barriers, and set a clear follow-up plan. These are the main books and resources that I used for the talk and things to look at for further reading, and then some other references there. If there's any questions, we can start with them now. Thank you.
Wonderful. Thank you, Amy. That's very comprehensive. And again, just to remind everyone, we'll have all this saved in the links We'll make sure the links work. Someone raised that, and the chat will all be saved on the so you'll have those materials you can look at. Just a question before we go to our next talk, Amy. So I know, at least at the IWK, the emergency department, they invested quite a bit, and a number of the doctors and the nurses actually took the crucial conversation courses. Like, is there evidence that, like, when you actually, if you do these as a group, that there's some improvement in behaviors? I know that's all tough to measure, but any comment on that?
Yeah, so the group actually that does the courses have studied that as well. And I think it's a bit intuitive. If the whole group has shared language, then if you do need to take a pause and bring up the, even just saying, oh, whoa, my opinion's not in the pool of shared meaning, or, whatever it is, that you can just use the words that we all have shared language for, I think certainly would be helpful. And then just being able to encourage that not just the leaders are learning these skills, but the rest of the team, then you can ensure that whole culture of accountability and communication.
Great, thanks. Yeah, the shared language, I think you're right. That's the key. Excellent. So we'll again we'll have more dialogue at the end of the of the fourth session. So our next one, we'll be going now to Dr. Faraz Al-Dara, who's from Petrolia, and he trained at University of Western Ontario and does a lot of work in rural medicine. And he's going to talk to us about leadership in the rural emergency department. So over to you, Faraz.
Thank you so much, Doug. I just want to make sure if everybody can hear me and can see my slides. Perfect. Excellent. I'd like to begin by acknowledging the land that I'm on right now is the traditional territory of the Etowandaron, Anishinaabeg, and the Lenape peoples who have longstanding relationships to the land, water, and regions of southwestern Ontario. And also, I do not have, I have not received any payment, funding, support from any corporations, organizations, or financial entities. What I want to do today is share lessons on leadership from non-medical sources. And I hope that just as it inspired me, to inspire you to lead personal and professional change and to draw on examples from a rural emergency department, namely the one that I work out of. So for medical literature, within our profession, we resort to medical literature for established and new guidelines and evidence-based protocols that make us good physicians and to exercise the best medicine for our patients. When it comes to leadership literature, there's a variety of authors and a variety of sources. You'll walk into a business section at a bookstore and you'll see many different books from CEOs, Army personnel, celebrities, and even athletes that talk about leadership. But the source that I'd like to use today is actually the authority on leadership. This is John Maxwell. Incorporated magazine named him as the foremost expert on leadership and management. He started as an evangelical, but he founded multiple organizations and camps dedicated to training leaders across the world. His most sold and quoted book is the one you're seeing, The 21 Irrefutable Laws of Leadership. And this is my personal copy here, which has been transformative personally and professionally in learning about leadership. And this is the book that I'm going to be using today to draw inferences and to draw examples from leadership in an emergency department in a rural center. So the first law, and the one that I thought had the most resonance with me, is the law of influence, where Maxwell writes, the true measure of leadership is influence, nothing more, nothing less. And there we go. He goes on to write, when people hear that someone has an impressive title or an assigned leadership position, they assume that individual is a leader. Sometimes that's true. True leadership cannot be awarded, appointed, or assigned. It comes from influence, and that cannot be mandated. It must be earned. That was profound to me because I always thought that leadership was tied to titles or tied to position. But Maxwell refutes that and says, actually, it's more influence, and that management and leadership are not the same. He writes that there are 5 myths about leadership, and I would have loved to have time to go through all 5, but I just want to focus on the first one, which is the management myth. And essentially, he says that there's a widespread misunderstanding that leading and managing are one and the same. The main difference between the two is that leadership is about influencing people to follow, while management focuses on maintaining systems and processes. He says that the best way to test whether a person can lead rather than just manage is ask that person to create positive change. Managers can maintain direction, but often they can't change it. And the statement that Maxwell uses in the chapter that was very profound to me was that managers do things right, whereas leaders do the right things. So what example can I use from our rural emergency department that highlights that? Personally, from the start of my career, I had an interest in pediatric and adolescent mental health. And as a family doctor and as an emergency physician, I found that there were challenges with resources, access, and more recently, increasing acuity and volume. And I wanted to find a solution that would help to attend to these issues, but away from the emergency department so we can focus on other issues that were critical. Not that mental health is not critical, but at the same time, finding a solution so that patients are not finding that they need help within the ER. So we formed a team and we engaged with the psychiatry department at our local university, the University of Western Ontario, and they were very happy to formulate modules over a weekend so that we were not busy at work. And it gave us the opportunity to familiarize ourselves with the newest diagnostic criteria, medications, management, and resources. And that was very helpful for those who shared my feelings about adolescent and pediatric mental health. But with the pandemic, a lot of the same issues arose, but we found that there were much longer waits, and out where I work, much fewer resources. So we sensed the need, and we wanted again to cater to these patients and the ones who are vulnerable and suffering, and say, what can we do for them so they're not relying on the ER? Because I can't tell you the number of times we'd hear, I tried calling my family doctor, but they just won't be able to see me. So out of that came the idea of formulating a mental health summit. The few emergency doctors who were very passionate about that invited members of healthcare teams, so from the hospital, from the clinics, from social worker and counseling offices. They invited community members, they invited political stakeholders to say, what are the challenges that we're experiencing as a community? And what can be some of the solutions that can attend to these vulnerable populations? Out of these invitations, what we've discovered was we as emergency physicians carried a tremendous amount of currency and influence, and that there was a tremendous amount of respect to us as leaders who are trying to help vulnerable populations, when it really just came out of a genuine goal to addressing the suffering within a population that needed help. The next law that I wanted to discuss is the law of timing. Maxwell writes, when to lead is as important as what to do and where to go. And timing is probably one of the more crucial elements in emergency medicine, but I love the stories that Maxwell shared in his book, where he talked about corporations, and he also talked about wars, but he starts out talking about Hurricane Katrina and the response to Hurricane Katrina in New Orleans and some of the surrounding cities in Louisiana. And he writes that when you take the wrong action at the wrong time, that causes a disaster. And he illustrates how the timing was so off in responding to people's needs and for evacuations that it created a cascade of wrong actions, one after the other. He also writes that taking the wrong action at the right time is a mistake. But the one that I found interesting was taking the right action at the wrong time. Maxwell writes that that can cause resistance amongst your followers who will feel that there could be doubt into your leadership. Another example that he brings about when he talks about the right action at the wrong time is entrepreneurs. He says that entrepreneurs exhibit a strong sense of timing, but the ones who make the greatest mistakes are the ones that mistime their actions. And that can cause tremendous amount of losses or tremendous amount of profit and financial repercussions. So that's the wrong action at the right time. And to get good timing and to reconcile that with good leadership, there are certain characteristics that leaders have to be aware of. Maxwell writes that for that to happen, for that reconciliation, leaders must have a firm grasp on the situation. If their motives are not right, then their timing will certainly be off. And they have to exude confidence, not just in themselves, but in their team. If they're decisive, then that could instill confidence amongst the team members. But if they're wishy-washy, then that's going to create a similar sentiment among the followers. Experience is something that is gained and it's nurtured just like decision making. And if leaders don't possess experience, they need to gain the wisdom from others who do possess it. And I hope that this forum that we're doing right now can be the initial step to forming a portal that we can discuss leadership lessons and leadership challenges so that we can gain from the experiences of others who may have been through the same thing. Intuition, right now, intangibles such as momentum and morale are issues in my emergency department, and recognizing those can help the leader make appropriate decisions and get good timing on it. And probably one of the more important ones, if not the most important one, is preparation. So the lesson from my rural emergency department is that early on in the pandemic, our current hospital reappropriated and procured PPEs for their own emergency department, for their own ICU, or for their own ORs. And that caused shortages within our own department, but there was also this unknown timeline of having supply chains that were compromised. And this is kind of a funny example how a global event and a global economy can affect a rural emergency department. So a decision needed to be made. A timely decision as to, do we rely on our established routes of supply, or do we make a timely decision to be creative and to be innovative of how to procure PPEs? And we went with the latter. So we reached out to the community. We put out Facebook messages. We went to the community. We used our social network engagements and asked, is there ways to engage people to help us out with our PPEs? And the response was immense. We were able to procure masks through the Conquer COVID campaign. We were able to get shields from, lucky enough for us, an emergency physician in London who has proficiency with 3D printers, as well as gloves from dental offices. While we were able to get PPEs, what the message also sent that we acted in a timely manner, and we were able to take the right decision at the right time. And that cemented our role as leaders and influencers for our team. And it was all about, being safe for ourselves and being safe for our patients and for our colleagues. But that step had to take place, and otherwise it could have had negative repercussions. In the interest of time, I'm going to just mention one more law from Maxwell's book, and that's the law of empowerment, where he says, only secure leaders give power to others. He writes, successful leaders have to empower others and help them to reach their potential. The example that he gives is the Ford Motor Company, where when they gave decision-making and power to multiple individuals from multiple talents, that corporation became very successful. But when jealousy and infighting and the fight for power took place, unfortunately, their fortunes were reversed. And he talks about businesses that relied on people power, getting power to be shared amongst multiple individuals, as opposed to positional power, where power was held in a hierarchy, and that the higher your position or the higher your title, the more that you contained. Now, in our rural department, we obviously have a very limited number of resources and staff, but we made it sort of our mission to make everybody feel involved and everybody feel welcome. So what we did was we told our younger staff, the ones who we were able to successfully recruit and who are the youngest of the group, is to take initiative and to make this their own department. With their interest and in their experience in point of care ultrasound, we said, why don't you look into teaching the ones who are not as experienced? Or why don't you look into getting programs to come to our department so that we can get some experience? And at the same time, why don't you also negotiate with some of the stakeholders into getting money and donations and purchasing a newer ultrasound machine, ones that you're familiar with and ones that can deliver for us the results that we were looking for. With teaching and mock codes, that file was given to nurse educators. Traditionally, it was held by physicians, but we felt, nurse educators have so much to provide and they practice so much with nursing. Let's give them a role. Let's make them feel that they're part of our team. And by having them take over that file, we're noticing that everybody feels involved and everybody feels empowered to kind of get our education, our comfort level with resuscitations better. So it's all about recognizing talent and focusing on people contributing towards the organization. I want to end by issuing a call to leaders. And by leaders, I mean the people who are here. I believe that we are all leaders and we have the potential to be leaders. COVID-19 was a time when ER physicians across Canada stepped up and informed the general public through media and through different means, and advocated for their colleagues, their hospitals, and their communities. And based on that definition of leadership of being influenced, I believe that was an inspirational display of leadership and proof that we all can be leaders as long as there's a commitment to learn and to improve. So I have a homework assignment, and I guess you can consider that as part of the interactive aspect. In that chapter on influence, there are certain characteristics. And the homework assignment, which I will share in the chat, is rating your characteristics on a scale of 1 to 10 and finding out which ones are essential for your day-to-day and which ones can there be room for improvement. Because as Maxwell says in his book, in The Law of Process, leadership develops daily, not in a day. And so if we focus on these characteristics, there is potential to gain influence and to become leaders and to aspire to lead and to make a difference in our departments and in our communities. And that doesn't have to be in a rural emergency department. That could be somewhere as big as St. Mike's. I hope that was as fun for you and informative for you as it was for me. Thank you very much for this opportunity.
Thanks, Faraz. Wonderful talk. And yes, absolutely. Put your homework in the chat, the homework assignment in the chat, and then we'll come back to that next week. I know Rod's on the call, and that fits in obviously with wellness and resilience. So that's fantastic. Really appreciate your input there. So we're going to proceed onward to our fourth topic of today. And this is something I'm really looking forward to because there's so many little things that emerge that drives us all crazy. So Carolyn Snyder is the Chief of Emergency Medicine at St. Michael's Hospital in Toronto, has had a leadership position there. It probably seems like 10 years, Carolyn, but really it's only been like 2, hasn't it, as the chief? So we'll turn it over to you.
Yeah, I think it's been 3 decades. I swear they hired me and they didn't mention that there was a pandemic in its near future. So it's funny you showed that picture of me, Faraz, and my family cracks up. They're like, that's like the after COVID versus the before COVID pictures of me. So I laugh at that because it's kind of a family joke about how tired I looked in that video. And I know that all of us felt that way, all of us on this call and our colleagues. I wanted you to know I'm in a hotel. And as a result, I'm having a little bit of spotty internet. I may turn off my video while I talk, just more because I don't want to crash get booted out with all of this, but I'll keep going back and forth as much as possible. So today I'm speaking about the fix the little stuff, and the reason this came out is very early when I started in my chief role at St. Mike's. I met with all of the staff physicians at the time. I think there were about 30 of them. And I wanted to know a few things. One of them was like, if I could fix anything in the next 6 months, what would it be? What about in the next 2 years? And what about by the end of 5 years, would those things look like? And there was a great consistency, but was really interesting is like when we put it within that sort of sense of over the next 6 months, there were some really clearly things that were actually felt very little to most people. And there was great frustration about the fact that they were little. And not yet fixed. And there were some great learnings for me as I went through that because I was new in this chief role in terms of operations, and they also felt little to me. I can tell you that some of those things haven't been fixed yet, but I'm going to talk through, but some of them did. And I'm going to talk through sort of the process of that and how to engage people in that process of understanding the little things that sometimes are actually hard to fix, but actually, and then also how we can go about doing that. But I'm actually going to ask all of you to participate. You can find it's helpful to do this on your phone at the same time, or you can, depending what kind of screen you have, if you could go to www.menti.com and 393530. All right. So all this is, for whatever reason, let's see if I can do this. There we are. So think about your last shift. Just remember the last shift you worked. I want to know, did you make a difference in a patient's life? Did you save a patient? Did you actually not save a patient, but let the patient's family, like, were you part of a very caring human moment with that patient's family? Did you actually fix something that's super easy to you, but made a big difference for that person? Did you stop and listen to a patient and they came out and talked about you that night? Those are all things that I believe make a difference in patients' lives. I'll give you just a minute more. Still a few coming in. I think this really speaks to the gist of this. There's a sub number that doesn't feel that way. And I think that's really important and telling. But I think it's also really important to acknowledge that many, many people did actually make a difference. And that's, that's what we got into this job for. And it's a really important part of our job. I'm now going to ask you to go on to your next question. And I say, what drove you bonkers? What were those things that just bugged you during the shift? And so some of these will be big, but some might be really little. You don't have to fill in all 10 that are options there. You can start filling them in and pressing enter, and you can then keep going and adding more. This is set up so that you can, difficult consultants, consultants, area, God, flow, lack of stocking, anti-vaxxers, yeah, no space. Being mistaken for the non-MD. Somebody says a splinter in a foot. Was that your own foot, or it was hard to get the splinter out on a patient? Documentation. Yeah, the staff shortage, nursing shortage issue is tough. Patients fully dressed instead of getting in there, and the patient's being, you have to go walk out while they get undressed, totally, bed block. All right, I think there's a lot of things here. Now, big wait times, nursing staff shortage. And so as a leader, I've started more recently to really take these concerns, because we all have them. There isn't one thing here that I find I don't also run into when I'm on shift and find difficult. But what I've learned to do is put it into one of three buckets. Are there things that I have no control over? That's, if government makes a change in a swab things at 4 o'clock, or swab requirements at 4 o'clock in the afternoon on a Friday, and I don't agree with them. I don't have much control over it. Or what those, certain other, like the fact that there's certain things that I just can't touch in my role as a leader. There are things that I have influence over. And so I've learned that in my leadership role, I can have influence on things that maybe not truly under my control, but I have the opportunity to be a voice that affects my team and our patients. And then I have an opportunity. The third one is, what do I have control over? And to me, that is the responsibility of our leadership team, truly. And that's where I feel we should be held accountable for. And so when somebody comes to me frustrated at the end of a shift, I sort of say, okay, this I can try and influence. This is how I'm going to try and influence. But so the control is outside of my own control circle, but this is how I think I can influence it. And that I think is helpful for those that finish that shift to sort of say, okay, I vented, or I've asked for something changed that and there's a difference there. And I think it helps with satisfaction in your leadership, but it also helps us steer our ship a little bit more. So I think we're supposed to, I've never used this one slide on Menti. I think we're supposed to take is there information on how we do this, but I think we can actually like pin where we actually perseverate on that shift. There's a few people pinning, so it seems to be working. That's good. Good. Interesting. There's a nice shift, and I can tell you that I can guess who perseverates on what within my group. It's really interesting. One of the things I've started doing at the end of shifts to try and help learners make sort of think about this is I actually have started asking them to reflect on what touched their heart at the end of a shift. And I want people to get into an opportunity to reflect that we do make a difference. It may be that we make it so often in people's life that we forget how important it is. But making sure that people do spend, from a wellness standpoint, some time reminding themselves that they made a difference. At St. Michael's, as many of you may know, we have a very high urban population with a lot of need. 20% of our patients are homeless. And it is fascinating to me how many medical students and residents start really identifying that as an area where they make a big difference. And I think they feel really empowered in a problem that they felt very disempowered at prior. So, but the reality is those frustrating things are really common for people to take home. And I think a lot of them, our colleagues, see them as the representation of our ability to lead and manage a department. So I've talked about my areas of control and not control. I ask these questions a lot, and this is the kind of like small little things. If we were to fix the little stuff in our department, this is the kind of stuff that comes back regularly. Tonopen's missing, it's broken. There's no tongue depressors in the ENT or swabs. We clearly have an issue with swabs, like the number of swab conversations we have. And, you know, we have had so many people do as their QI, like residency program, fix the swab problem. Which swab do you use when and how does it get labeled and where is it in and which bucket is it in and how does that get bucketed and who's stocking it and why are stocking the wrong swabs. And as we all know how incredibly frustrating it is to do that exam with the wrong swabs and not none of the swabs at your bedside. And so this is my final slide, but it really speaks to the approach that we're taking in our department. So we actually have a sheet of paper that goes up in each of the zones. And when you notice that there's no otoscope in room B2, you are supposed to actually put it on that sheet of paper. We've tried all sorts of things. My deputy chief gets so many emails on this. It's like, there's no otoscope in B12 and you put it in, he puts it into a bucket and every week he sits down with the inventory management guy and they try and get those fixed, etc. But actually seeing it up there is really helpful. Because people say there's no, you know, the swabs are all a mess and they walk in and they see somebody else just put that in the last shift. They know that Alan's going to see it, that Jonathan's going to see it, and that it's going to be fixed. And when that gets crossed off, they know it's fixed. They're not the only one. But what we've also learned are things like swabs are far more complex than just being stocked properly in the same thing. For some reason, it is like the elusive problem at St. Michael's Hospital, having the right swabs in each room. And so our team is planning now to come back together to co-design again a better system for the more complex. However, we've decided to look at it in a very interdisciplinary way. So previously the whole swab thing was, you know, an MD resident doing a QI program and with the inventory guy and one of the people from lab. And what we're learning is that actually we need everybody who would ever touch that swab in the process to be part of that co-design team. And when we get right down to it, actually one of our bigger problems isn't necessarily that we don't have a system that might work, but that we actually have a problem that the people who are stocking don't probably understand the importance of where those swabs go, which swabs, the correctness of where those swabs are, or what make their job makes a big difference. And so we're planning to involve them in this co-design team to try to better deal with, especially some of these, what should be really small but it's in our day-to-day job. But what we also need to do is create a sustainability plan, because you can't just do quick fixes for first 3 months and then let it go. There has to be like a who's in charge, how often do we meet, what day of the week do we pull down each of those sheets and put up new ones and then walk around and try and get them fixed, and even put out a report so people know that we're working on the quick fixes, that we're not ignoring their requests, that we have acknowledged that. And we also need to go back to the drawing board regularly when the things start. So as part of the reason I've added this fourth point is we had a great system going for our first sort of year of this, and then COVID hit, and we got so obviously intertwined with the supplies and the processes associated with it. We stopped putting up those sheets of paper, and it's really been in the last 4 months where we realized like it's a bit of a disaster again. The swabs are a mess again, and so we're redoing this, but that's why we're going back to our drawing board with a new co-design team for some of these more complex pieces. And that's the end of my presentation. I'm happy to have more conversation, answer questions. I will stop my share and put my screen on in hopes that I don't have any difficulties.
So with that slide with all the stuff that drives us crazy, that's got to be a CAPE poster. That's fantastic. Okay, I'm going to hand it over to Eddie.
Thanks, Doug, and thanks, Carolyn, as well, to all the great presentations this afternoon. We've got a good amount of time for discussion. Rod, I see your hand is up. Why don't you go ahead?
Carolyn, I have just a couple comments and just a question more for me. One comment is, it's funny, the otoscope one that came up, and I was other things that you can influence, and I was harking on people for, I don't know, months and months and months. And finally the manager said, the biomed used to do rounds in the morning, and why don't we reinstitute those rounds? And actually, ever since that happened, it fixed the otoscope problem. So I don't know, but like they actually will go around, take care, check everything, and make sure everything's working, because that was just an absolute disaster for like 6 months or whatnot. What do you?
That's a great idea.
Yeah. What do you do about, Carolyn? What do you do when? This is from a leadership resilience point of view. When people bring up things that clearly are not in your control, usually around, when someone sent a referral wasn't appropriate, or someone did this and has disrespected us in terms of Emerge, and a lot of things that are relationship that are outside of our scope, but clearly very frustrating to people, our colleagues. I try to show a lot of empathy, but I really can't influence that very much, but it keeps coming up over and over and over again. I'm just wondering kind of what your tactics of, keeping a positive energy around those kind of complaints you can't really influence.
So I think actually the very first part is empathy and reflecting back to them, not just, wow, that's really frustrating, but it really does make us feel devalued, doesn't it? So you could try and get to the root of what's so angering about it. And then I actually tell them about 3 buckets. Okay, is this the kind of thing that I actually have control over? And so I think people are getting used to me now, sort of saying, okay, this is something that I have control over. You're right. Okay, so let's think. Now, if I was to do this, do you think that would help solve the problem? I engage them in that decision making, right? I've had this conversation with that consulting group multiple times, and that's clearly not working. Here's what we've done so far. What else do you think might be useful? And I often find that's that point from, instead of standing in my door in the office, they sit down and now they're a part of it. And then they feel heard, they empathized with, and then we sort of try to co-create opportunities for solutions. When it is something outside of our control, it is something like, I think I have personally some post-traumatic stress related to 4:30 p.m. on a Friday afternoon. And in Ontario, I can see people who are working in Ontario will know full well that during COVID, that is exactly when information announcements were made. And it didn't matter because there was no difference between a Friday and a Saturday and a Sunday during COVID. But incredible frustrations, because those announcements were made in the newspaper or on the news at the same time as we all learned. And it was so difficult. And so I was able to share with people my frustration too, in a way that I felt was mostly diplomatic, and say, this is really hard because I feel like we're trying to have control over these things and we don't know when this is coming either. here's what I'm going to suggest we do, and what do you think? And so really sort of saying what is in our locus of control, and then being able to concentrate on that, but also sort of saying and then sometimes it's like they think I have influence on something. I'm like, are you kidding me? I mean, like, really, I don't have influence. Like, it's an interesting thing, but that's also helpful to level set where I have control, where I have influence, and where I don't.
Great stuff. I see, Monica, you've got your hand up, and there's been some really interesting stuff in the chat about gratitude practice. Alexis has put a presentation from Rob Orman in there, and I think it traces back to that really cool dichotomy that you showed, Carolyn, and how people fall into the frustrating versus made a difference camp. So Monica, go ahead. I don't know if you wanted to address that as well.
Sure. There's actually a couple of things. So Rod, in response to the idea that people come back with stuff that you can't change, sometimes you have to sort of flip the idea on its head a little bit and maybe look at it in a slightly different way. If there's really that many people complaining routinely about the same thing, then it is a problem. And then it's not about you can't change someone else, but maybe what you can do is empower people to share how they feel with the source of the frustration. You may not change another person's behavior, but you can try to educate them. And every once in a while it works. And if it empowers people to feel like they're making a difference in what isn't working for them right now, then it may not actually be a wasted effort. So that's one comment. And it may not apply directly to what you were thinking of, but I think it's a general principle to always consider that, you know, we really focus on, well, I can't control this, I can't control that. But you can control how you behave in response to the situation as it exists. And sometimes taking control of your response is the best way to manage the frustration. And giving them something constructive to do as a response may sometimes alleviate the greatest part of the frustration that goes with the problem.
Monica, thank you. And I think, you know, that's exactly what I was trying to get at about getting in and co-deciding how best to deal with it. Yeah. I think there's also some level setting. Sometimes it's necessary to be clear that, I got to be clear. The expectations on us as leaders are actually impossible to meet sometimes. And I think that's something that people thought we were available 24/7 for 4 to 8 months, and then there isn't one leader I know that didn't at one point sort of have a crash of some sort, right? And I think that being clear that we too are human is a really important piece, because the expectations rose remarkably during COVID.
Without a doubt, without a doubt.
We have to level set the group, right?
But I think you also have to allow other people who aren't in leadership to take some of that weight off your shoulders. I think there's a certain amount of this sort of constant sense of responsibility. I have to solve this person's problem. I have to solve that problem. I have to solve this problem. But you can't solve everybody's problem. But what you can do is get more people involved in solving their own problems and solving problems for each other. And I think the more you empower people, one of the things that we found specifically in our shop was, to be perfectly honest, it's scary to say, but the pandemic brought us all closer together. Pandemic actually improved morale in my shop. Yeah. Because it finally gave us something common to focus on, and it reshifted our focus onto each other. Whereas we had gotten to a point where everybody was just so focused on how crappy things had become and how hard it was for me or me or me. Having that external locus of concern was so important to changing the mindset in our group. And I mean, there were other things that happened over time, but I think it's really important. And the gratitude, I think, it's funny, we all sort of snicker and say we know who falls into which side of that little capsule, who, focuses on the frustration and who focuses on the good. But you can slowly change where you sit in that capsule. And it can sometimes happen over minutes. Sometimes it happens over hours, and sometimes it happens over a much longer period of time. And I think, Carolyn, the little comment you made about asking the learners to reflect on what they did well, or what was a positive impact, or what they found heart sort of warming about the shift is great. But the gratitude practice, honestly, is fantastic. And it's so simple. And it's, just grab a little book, a note, notebook and a pen, put it next to your bed. And the last thing you do before you go to sleep is you write down anywhere from 3 to 5 things that you're grateful for that day. And it's funny, last night's list for me, 4 out of the 5 things were actually good things that happened on shift. And it was a shift from hell. So it completely reframes the day. And so that when I wake up the next morning, that shift isn't quite as dark and horrible the day after as it was when I was in it. And these are small mind shifts that happen really subtly over time. So even, you know, if there's a bunch of negative Nellies in your department, maybe put in a gratitude moment for each of your meetings, where everybody goes around the table and says something that they're grateful for that's happened in the last week within the department. Maybe it was a really great interaction with a consultant, or somebody said something really nice to them, or we got another letter from a patient to say thank you or whatever. Like, these are small things that you can steer an entire group of people towards doing without them actually realizing what you're doing. So it may actually have a beneficial impact overall. Just a thought.
Great suggestions. I've seen a couple of people come off mute. I don't know if people are willing or going to weigh in. There's some really interesting discussion in the chat. Amy, would you want to pick up on how some of this discussion relates to the helpless story that you were talking about from Crucial Conversations?
Sure. So there are certainly times, as was said, that when we're leaders, we do need to delegate. So don't take on the weight of the world. But when it is an issue that's yours, that you're looking at it in a crisis and you're like, there's nothing I can do. This is definitely out of my control. Or I can't talk to that consultant team because it's going to be too difficult or cause problems with my working relationships. Just remembering that, you know, you can find solutions to these problems. It's just about coming from shared common ground and mutual purpose.
Amy, you know, and I think actually hearing some of these comments, if I could respond, I want to be clear that when I talk about things that aren't in my control or influence, I actually am often talking external to even like the 4 walls and the systems we work in. I think, you know, there are things like none of us on this group are going to be able to make a big impact as far as I can tell. And we may have small influence on the meth crisis, right? But we're seeing it in our department. So we have control over how we respond. And so I think that's the piece, is what do we actually have control over, and shifting to that piece. And I think that's the importance of what I was trying to respond to there.
Katrina, I see you come off mute. Was that you trying to weigh in with something?
Yeah, I was just going to say that, you know, kind of like what, can't remember if it was Carolyn or Monica who was talking about saying, having like a moment of gratitude, like at a meeting. You know, we have check-ins at the beginning of our EP meetings, and the check-ins are sometimes it's a variety of things. Sometimes I use a check-in so that people can say something about themselves as an opportunity for people to make connections. So like, what's your favorite movie or what's your favorite TV show? Sometimes, you know, and this is like, it takes 10 or 15 minutes. And I think for some people, it may be something that they wish to avoid. Maybe they want to join the meeting 15 minutes late so they can avoid that moment. But I also think it's an opportunity. We did it before Zoom. I think it's even more important in Zoom because we don't see each other. We don't have those moments to kind of amble in and make those connections before we have our meeting. Sometimes I use it to, you know, I think at my next meeting, I just said by text to Katie and Jason, who are here from our group, that in my next meeting, I'll have to use it as a gratitude moment so everyone can say something they're grateful for. I've used like, if you were a weather system, what weather system would you be today? And I remember a moment where someone who's very mild-mannered said cloudy with a chance of thunder. And I was like, whoa, not what I was expecting. So, you know, the check-in can be used for connection. It can be used for something different. We did poetry last time, but, you know, I think that there's lots of opportunities to do that. Oh, I like ice cream rounds.
Great suggestions. I mean, while we're on the topic of ice cream rounds, I don't know if everybody knows what they are. I see Huma is with us. Huma, are you able to come off mute? And I know you've led a lot of work at South Health Campus or I may, yeah, oh, great.
Yes, sure. Sorry, I can't have my video on. Ice cream rounds are, I guess, similar to Schwartz rounds. Schwartz rounds are based out of the Schwartz Center for Compassionate Healthcare, affiliated with Harvard University. And the idea is that you have, it's essentially rounds where you discuss the emotional, social, and ethical aspects of providing patient care. So Schwartz rounds are very structured. My understanding of ice cream rounds is that you'll get together. Typically it's one discipline in ice cream rounds, but I guess you could do it multidisciplinary. And you'll talk about the hard stuff, and there'll be a topic of conversation or a case presentation, and you talk around the ethical, emotional aspects of providing healthcare. Schwartz rounds is typically multidisciplinary. You'll have 3 panelists, like a social worker, a physician, and a nurse, talking about either a particular topic or a particular case. And the participants and the attendees are essentially participate in dialogue around either the case or the topic. Yeah, they're very, very moving. And every time I've attended Schwartz rounds or facilitated, I've always felt like these are the conversations I want to have more. All the other stuff that are so important that we don't really talk about.
Fantastic, and will certainly be a great segue to some of the other sessions we have coming up. Well, we've reached our time. I know we can go over if we wish, but I also want to be respectful of the time that you've committed to this series. And if there are there any other questions or thoughts that people want to share at this point? Okay, well, if not, a huge thank you to our amazing speakers today. Great presentations. Thank you for taking the time on this Remembrance Day to join us on this leadership series. The evaluations will be coming out shortly, and we'd love to have your feedback that we will definitely incorporate. And if there's nothing else, I'll wish you all a fantastic rest of the afternoon and evening. Stay safe. Be well, and as much as you can, be grateful for the good things in your life.
And Eddie, if I could just do one thing. For next week's session, there was a doodle, a Survey Monkey sent out, and about half of you have completed it. We're going to resend the link out. If you can take the time, if you haven't had a chance to complete it, to do so. Thank you.
Excellent. Doug, Caroline, any final housekeeping or other issues to attend to?
No, just fill in that form. That'll help design the session that Rod and Huma and James are leading for next week. So anyways, great chat. We'll have all that saved. It really is our syllabus, if you will, and look forward to next week. Caroline, anything else we're missing?
No, I think that's it. You'll see an email from me shortly. It will include, again, that link for next week's homework and for our evaluation for this session. All
right, and do Faraz's homework too. All right.
That's right.
Take care,
Good night, everyone.
Bye-bye.